Hello and welcome to the third lecture in the Principles of Exercise Therapy continuum. This week we're covering the mind-movement connection. Remember that movement comes from the brain or the mind, not from the muscle. So we'll just go over what physiotherapy is about. This is our centering slide. It's concerned with human anatomy and physiology, human movement and function, maximizing a patient's wellness and potential, and minimizing disease and injury. Ultimately, it's about solving real-world problems, and that's why we're here as physiotherapists. So, with the mind-movement connection, what we want you to learn by the end of this session is the following. We want you to be able to describe how movement starts in the mind. We want you to describe motor milestones in pediatrics and their relevance to later development. We want you to explain the concept of functional movement and why this is important in exercise therapy, and then a new concept that you might not have heard of before called physical literacy. So just like learning to read and write and do maths, your physical literacy, your ability to move in a way that you want to, is just as important. So that's the new concept that you might not have heard of before. Let's define exercise. So exercise is a subset of physical activity. It requires physical effort and it's carried out to sustain or improve health and fitness. From the Latin exere, which means to keep busy or practice. The military say that we go on exercise. What they're doing is they're practicing maneuvers and of course keeping busy at the same time. The way we remember exercise is through the acronym REPS. So a physical activity, in order to be classified as an exercise, has to be repeated. It has to be planned. It has to be purposeful, and it has to be structured. Without these, it's merely just physical activity. So just remember that, REPS. So here we are with the physical activity as the overarching theme. And within that, you've got sport and exercise. So these are some old guidelines, but basically we want to increase our physical activity to 300 minutes per week, and we're thinking about 90 minutes of either sport or exercise is enough to give you health benefits. These have changed since, and we'll come on to the guidelines later. So the principles of exercise therapy. This is remembered with the acronym ASPORT-BILI. Remember that it's about adaptation, it's about specificity, it's about progression and regression, overload, reversibility, taking time out, behavioral change, probably the most important part of exercise therapy, individuality, lifestyle integration, the law of diminishing returns, and of course your responsibility. Health is about giving the responsibility back to the patient. So the mind-movement connection, or we call it neurology, which is basically the study of the brain and how that relates to the nervous system also. So we've got the sensory and motor nature of movement. You've got sensory nerves, and you've got motor nerves. You've got to understand the importance of muscle tone, too much tone or too little tone, particularly with your neurological patients. This will be far more important when you go and do your neuro placement. We've got to focus on task-orientated movement and not isolated movement. There's been a tendency in exercise therapy for us to be 1980s bodybuilders and not integrating the movement into what needs to be done, just focusing on the muscle, on the assumption that by just getting the muscles strong and activated, that will help with the movement, which is not necessarily so. We've got to think about motor development and motor milestones, particularly in pediatrics. One of the most important things I learned is, how does the spinal system, the neurological system, how does that respond to the development when you're young? Motor control, motor patterns, and motor dysfunction. So all movement comes from the brain. If there's an error in the brain, there will be an error in the movement with regard to control, patterns or schemas, and of course dysfunction. So we have some terminology. Motor is movement. Functional will refer to anything that is task orientated. Pediatric refers to really young children and babies. Dysfunction means poor movement quality. Milestones, these are your achievements along the way. If you don't get these, it's called failure to thrive. And then, of course, physical literacy, which is the importance of the child and indeed the adult acquiring these abilities and skills so that they can move in a way that's confident and competent, that they understand how their body works, and that they can do any physical pursuit that they require as part of an integrated lifestyle choice. So postural control. So your posture is really a frame of reference that your body has. In particular, your head needs to stay upright, your eyes on the horizon. That's the way your cranial nerves work best. You'll notice this, that if you're inverted doing a handstand, everything is much harder because you're a bit discombobulated about where you are in space. So it's the ability of the bodies to control this position within space, and there's a complex interaction between the neurological system and of course the musculoskeletal system. We refer to equilibrium or balance in both static and of course dynamic movements. An object is considered stable when its center of mass is over its base of support. We'll do more of that when we cover balance and proprioception. So what is motor control? Remember that the brain knows movement patterns, not muscles. The brain doesn't say flex my bicep. Okay, it doesn't say tense my tricep. It says bring my hand to my mouth because I'm eating. And that's important because that's the basis of functional movement patterns rather than training muscles. So remember that we train the brain, we're not training the muscle. And imagine that each motor pattern we have is like a book that sits on a shelf. Every time we want that motor pattern, such as something like a tennis serve, we just get that book out, dust it off, and after a couple of times we're able to reproduce that movement pattern. Remember that these motor patterns are planned in advance and executed without many changes in a very short period of time, literally microseconds. And we have this skill memory that's processed in the cerebellum and relays information to the basal ganglia, and it stores automatic learned memories, things like tying your shoelaces, playing a musical instrument, or indeed riding a bike. That's where you never forget. So we've got to think about the brain, the central nervous system, and the peripheral nervous system, skill acquisition, skill being the learned ability to bring about predetermined results with maximum certainty, often with minimum outlay of time or energy or both. We've got to think about movement patterns, we've got to think about your posture, and relate this to pathology. You know, how does movement change if the young child has cerebral palsy, for example, and related to potentially abnormal anatomy or physiology. So measurement of motor learning. We've got this acquisition of skills, acquiring new skills, and that's what a young child is doing all the time. Retention, their ability to retain these skills. It's no good learning a new skill unless you've got to practice it. We refer to 10,000 hours to become a master of that particular movement. And then they've got to be able to transfer these skills into other movements, and that's what physical literacy is all about. It's about that skill transfer of movement. And you're not going to be able to learn that in a single session. This is something that takes time. But remember, a skill is not learned until you can retain it and you can transfer it to other things. So pediatric milestones. Within the young child, okay, young babies, the first thing they do is they develop head control. They've got to be able to see what's going on and what they're doing. And that's from our hunter instinct. Okay, all our senses are all on our head, and it needs to be orientated into what we're looking at. Then we're going to learn upper quadrant control. The arms, you'll see babies just push up naturally, pushing themselves up as they develop that upper quadrant control. Then they gain sitting balance. Between 4 and 6 months, they should just be able to sit there on their own, where they're developing the musculature and the tone and the skills of just being able to sit up. And you'll see sitting balance with your neurological patients who've unfortunately lost that due to maybe having a stroke and they've got hemiplegia on one side. Rolling, being able to roll in bed is a classic skill, and you'll see babies in the early stages they can't roll, and then eventually they're being able to roll from their front to their back, and that's a skill. And then crawling, this is our mammalian reflex. Okay, crawling is very natural for us as well, on our hands and knees, as part of that quadruped reflex within the spinal cord. And then eventually we come to standing, and this is a skill that between 9 and 12 months roughly, most babies should be walking by about 12 months, and then walking definitely by a year minimum. If your baby's not walking, then it's a failure to thrive. So we've got some examples of young baby crawling there, and then somebody crawling, doing a bear crawl, for example in Tough Mudder, using those skills as an adult, and then some in the bottom right hand corner doing the quadruped functional movement screen that we come on to later. So when we're talking about motor mechanisms, we're talking about body alignment, which minimizes that gravitational force. We're talking about muscle tone, which will refer to our posture, and it basically keeps the body collapsing against gravity, holding us up. Then we've got skill acquisition. As we said before, NAP-defined skill is the learned ability to bring about predetermined results with maximum certainty, often with a minimum outlay of time or energy or both. So the 4 P's of functional movement, this is important. Functional movement has a purpose, it's task orientated. Then it has a particular posture. Where are my limbs in space? For example, a golf swing. How do I know I'm maximally wound up in order to get that maximal drive through? The position I'm in. Am I standing? Am I sitting? Am I walking? Am I lying down? And then the pattern will refer to the functional movements that we'll come on to now. So in terms of functional movement, we've got 7 functional movements that have been identified at level 1. These are our foundation movements. Pushing, pulling, twisting or twist resisting, squatting, hip hinging, lunging, and of course gait or walking, running. So these are primal patterns, and they're involved in all types of exercise. You can see the athlete doing all types of different exercise there. Then we've got level 2 movements. These are combinations of level 1 movements. So we've got running, jumping, hopping, throwing, and catching. These are all higher skill movements, level 2. There's an example of people jumping and people throwing there. A bit of plyometrics there, stretch shortening cycle. Then we've got level 3 movements, which are athletic movements. Okay, true plyometrics such as triple jumping or press-ups with a clap. And then we've got our gymnastic movements like burpees or Olympic lifting movements like the clean and jerk. So this is an example of a burpee. Okay, someone's down into all fours, doing a press up and then explosively jumping, clapping above their head. And there's somebody Olympic lifting performing a movement called the snatch. So we've got to put the fun in functional movement. That's important. To the patient, the movement has to be meaningful. It has to be motivational and empowering. Part of their normal physical activity, and they've got to be incorporated in part of their independence, such as the squat being sitting to stand. If you can't sit to stand, okay, then you can't move about. You lose your independence. As far as the physio is concerned, it's got to be functional. They've got to be the motivator. They've got to empower the patient with exercise and assisting in that exercise so that the patient learns the technique. So physical literacy. This is mastering those fundamental movements or sports skills that allow a child or indeed an adult to read their environment, making appropriate decisions and allowing them to act with confidence in a wide range of these physical activities. And physical literacy will underpin all exercise therapy. And you'll get somebody that moves well, a movement master, and somebody that moves very badly and they're a motor moron, if you'll pardon the term. So physical literacy. So the physically literate individuals consistently develop the motivation and ability to understand, communicate, apply, and analyze different types of movement, particularly in martial arts or dance, or more complicated movements like gymnastics. They're able to demonstrate a variety of movements with confidence, competence, creativity, and they can be strategic about that movement. Okay, different types of jumping, for example, jumping on one leg, jumping high, jumping long, all these sorts of things. And this will ultimately enable them to be healthy, make active choices, and be respectful of themselves, others, and their environment. So we've got to establish the exercise habit, and we've got to do that while children are young. Without the development of physical literacy, that's going to stop children choosing physical activity, exercise and sport, and make them more likely to be unhealthy. And the Canadian project, which funds physical literacy, has some really good research on this. So we've also got to think about disability and physical literacy. So through no fault of their own, some children will be born either with a physical impairment or indeed a cognitive or behavioural impairment. And we've got to learn the skills to help them incorporate an active lifestyle in exercise, sport and physical activity despite their impairment and their participation restriction. We should be able to work around that so children with any sorts of disability can be as active as their able-bodied counterparts and help them in these early stages to enhance their motor skills and optimize their potential. So by the end of this lecture, hopefully you now know that movement starts in the mind. The brain runs everything, not muscles. We don't train muscles, we train the brain. We are able to describe those motor milestones and of course their relevance. We now know the term and the concepts of functional movement, levels 1, 2 and 3, and we're able to explain the term physical literacy and what that means. Okay, there we are, the developmental cycle from baby to adult. Thanks for listening, and we'll see you in the next podcast. Bye for now.